Good evening, listeners, and a warm welcome to Views on Health. In the year 2021, we kickstart our program with Dr. Thathya De Silva, consultant general surgeon who has a special interest in breast surgery. And Dr. Thathya De Silva is attached to the Army Hospital in Colombo. Welcome, Doctor, in the new year 2021 to SLBC and to the program.
Wish you a very happy new year too.
Thank you, and we wish all our listeners a year full of health as always, because health certainly is wealth.
Definitely.
Having said that, focusing on the specialty of Dr. Thathya De Silva, which is breast surgery, may I hand the microphone over to you, Doctor, to start off in your area of specialty in breast surgery.
Yes, so I think breast cancer, as everyone knows, it's a very it's an important thing, especially for all our ladies to be very well aware of. The main reason is this is actually the second most common cancer in the world, second only to lung cancer, and it is the most common cancer that affects females in the world. So in 2018, the Global Cancer Observatory done by the WHO said that there were more than 2 million newly diagnosed breast cancer patients, and out of which there were more than 600,000 deaths due to breast cancer alone. And in Sri Lanka, in that same year, there were over 3,000 newly diagnosed breast cancer patients, and it was the second cause for the deaths. So as you can see, breast cancer is something that everyone needs to be aware of, because one of the important things about breast cancer is if it is detected early, it is curable. Patients should not have to die of breast cancer. So this is why everyone should be very well aware of it, so they can diagnose it early and prevent a very bad outcome.
Thank you, Doctor. Now, breast cancer is a topic that we have been focusing on in this area of the program, because certain ailments need to be brought into focus. Because of, as you said, they're common, number one, so more and more people are affected. If you take dengue, it's rampant. There was a time when dengue was like seasonal, if you know what I mean. The rainy season, you had dengue, but now it's throughout the year you find dengue cases. So we are coping with the pandemic as well at this point in time, the COVID pandemic. Yes. So but that hopefully in the foreseeable future we can overcome that.
Yes, definitely.
But if you take things like, you see, like breast cancer, diabetes, some of the non-communicable diseases, and dengue, that ailments of that nature, we keep refocusing because of the importance of creating the awareness with our general public. And so, like you said, yes, if detected early, yes, but then to detect, somebody has to come forward and say, I think I have this problem. You just can't go and say, do you have diabetes? do you have breast cancer? You can't do that for that matter. So the onus is on each individual, in this case the women, to do what needs to be done for themselves. And then if they do have any doubts, to come up to you, any doctor, and say, I have this problem. So how should one go about this, doctor? We will go back to the basics. It doesn't matter, because the more we talk about it, the more awareness we create.
Yes. Well, if you look at the ladies, and actually, before I start off, I want to say that there's this misconception amongst the society that this is a disease of the ladies only. But I want to stress that it is actually not a disease of the ladies only. It is a disease of the gentlemen too. So whatever I'm going to talk about is applicable to both sexes. Obviously, being a lady puts you at a higher risk, but that does not mean males don't get breast cancer. They can also be affected by breast cancer. So having said that, if you look at the population, there are you can divide them into two sets. There will be patients who will come with symptoms, and then there will be patients who have no symptoms. So first of all, I'll talk to you about the patients who have symptoms, because most of the time a lot of ladies, they don't know what to do if they detect any problem. So first I'll tell you the most common ways, that the most common symptoms that you should be aware of. So as you all know, I'm sure the most common presentation to us is with a lump in the breast. Lump in the breast does not mean it's cancer always. A lot of ladies are very worried to come to us because of the final diagnosis that may be made. More than 95% of breast lumps are non-cancerous. But if you do detect one, it is important to seek medical advice and confirm whether or not it is. Then it can be a lump in the armpit. That can be because if it is a cancer, this cancer cells, the first place that it spreads to is the armpit, the lymph nodes in the armpit, and then you can present with a lump in the armpit. Then there can be certain changes that you detect in the skin. One is skin dimpling, where there is a little dipping in of the skin, mainly because the breast cancer cells go along these ligaments and pull the skin inside. Then you can have a red edematous swollen breast. In medical books they refer to it as poddy orange, because it gives an appearance of an orange. It actually looks like the picture of an orange. Then if patients do come present late, this is not very common these days because of awareness, they can come with ulcers or big wounds on the breast. Those are the common skin changes. Then of course there can be changes in the nipple. It can be a nipple retraction, where the nipple is pulled inside. It can be a nipple, there can be a rash around the nipple with nipple destruction, or there can be a nipple discharge. When I talk about nipple discharge, I want to specify that it is a common thing to have nipple discharge. But what you should be worried about is if that nipple discharge is on one side and it is blood-stained and it spontaneously is expressed. These are the features that you should be aware of. And I also want to mention about breast pain, because this is one of the most common symptoms that actually brings ladies to us. Pain is not a very common presentation of cancer. You generally don't, if you do have pain, that is in a patient who comes quite late on in the disease, where the cancer is quite significantly large. So it's not a common presentation. However, you need to see a doctor and confirm that there is no underlying problem. So these are the common symptoms. So if you have any of these symptoms, what do you do next? That's the next thing you need to know. First of all, you need to go and meet a doctor. When you meet a doctor, there are a few steps that they will take you through to come to a diagnosis. First thing, they will take a detailed history to see, talk to you about the duration of your disease, whether you have any risk factors, and so on, and any signs and features suggestive of a spread of the cancer. Then the next thing is they will obviously examine you to get an idea as to what kind of disease we are talking about. And then the next important thing is they will do some form of imaging. So when we talk about breast cancer imaging, there are two main ways that we do this. This is one thing is through ultrasound. The next is through mammograms. Most of the times, one of the common things that the ladies come and ask me is, do we have to have a mammogram? Can't we just do an ultrasound? There's actually a reason why we have two things. So generally, if you take the anatomy of the breast is mainly it's composed of glandular tissues and fatty tissues and fibrous tissues. It's a combination of this. So obviously 40 years and younger, you will have more glandular tissues because the breast is created for mainly breastfeeding. So in those cases, 40 years and younger, yes, an ultrasound alone is enough to detect the features suggestive of a cancer or anything. But with age, the glandular tissue decreases and the fatty tissue takes over. So if you want to assess the fatty tissue, the best investigation is to do it through a mammogram, because even the smallest, earliest changes can be detected on this mammogram. So small signs like calcification, these are signs of early breast cancer. And the next thing patients ask me is, it's really uncomfortable. Is there any other way we can do it? Because people who have actually undergone it know that you have to press the breast between two plates, and it's not the most comfortable thing. Yes, I agree with that. But the reason they need to do it is they need to press the breast to detect every single layer of the fatty tissue to make sure that they don't miss a cancer. A third common question that they come and ask me is, by doing this, aren't we exposing ourselves to radiation, and won't that itself cause cancer? If you actually look at, it generally takes 0.1 millisieverts of radiation for a mammogram, whereas you are on your day-to-day life annually exposed to 2.4 millisieverts just from general background radiation. So this itself should show that no, you're not going to be put at a higher risk of developing breast cancer just because you do mammograms. So going back to the sequence, so after imaging, for some unfortunate reason, say you do see something on it, the next thing is we need to take some cells from that area to come to a diagnosis. And how do we do this? Mainly through either we can do something called fine needle aspiration cytology, where we put a needle in, or we take a tissue piece through something called core biopsy, and we take this, put it under a microscope, and come to a diagnosis. So these are the things that we do to detect a breast cancer. So if anyone has got symptoms, you should be aware and get this done to make sure that you don't miss a cancer.
Thank you, doctor. So this is the initial test that you go through to detect it. And obviously, if at that point in time, say it's all negative, one doesn't have to worry, obviously, but if it shows that there is something that is sinister in the system, then you take it forward from there to address it.
Yes.
So could there be like more than one cause, or one sort of sign or symptom that would lead to the final diagnosis?
So the final diagnosis, as I said, examination, history, and imaging, those are important. But the final diagnosis is made on tissue biopsy. Until proven otherwise, it is a cancer. So that is why we have to take the cells to confirm the diagnosis.
And how long does that take for the result to come back?
Generally, if it is just a fine needle aspiration cytology, within a day or two, you do get it. But we generally prefer to do core biopsies because there are certain factors that we have to check in these tissues, not only the changes in the cells, but there are certain type of receptors that actually guide us in planning the management of a patient. So generally, to do that and process the tissues, approximately 5 days to 1 week, within that time you can get a report.
So what would that test entail? How is it done?
So that is generally most of the times done by the radiologist, because through under ultrasound guidance we can 100% target the exact correct area, and it's a bit the core biopsy needle is a little bit bigger than general normal needle, so the radiologist will give you a little bit of local anesthetics to that area, and once it is numb, they put that needle through while looking at it on an ultrasound and take a few tissue parts to send for testing to the pathologist.
So that's the process there.
That is the process, yes.
And is it very uncomfortable? Because these are questions that people tend to ask.
It's I won't say it's absolutely not uncomfortable, but once the pain is mainly when you're giving the local anesthetic, you need to inject something, so that might hurt. But once the area is numb, generally it is not very painful.
Now, the next thing, doctor, having come up to this point of testing, and you find that it is positive, we need to go forward from there. If it's negative, there's nothing to discuss in that sense.
Yes.
So if it's positive, then what happens next? What would you do? So
if it is positive, when you talk about the breast cancer treatment, we can broadly divide it into surgical management, chemotherapy, radiotherapy, and hormonal therapy. So it is basically a combination of this that will entail the treatment plan. But unlike the good old days where a single physician makes the decisions, it's not like that anymore. Worldwide, we put each and every single patient's case through a multidisciplinary team approach, meaning that there are multiple consultants or specialists from their respective areas who get together and decide on what the best best treatment plan is for that particular patient. We always try to individualize the treatment plans for each patient, because studies have shown that that gives the best outcome. So in the case of a breast cancer, there will be the breast surgeon, there will be the radiologist, the pathologist, the oncologist, and where necessary a plastic surgeon. So we will get together and try and make a treatment plan. So the type of mixture of the things that I told you will depend on multiple factors. It will depend on the type of cancer that you have. It will depend on the extent of the cancer that you have. It will depend on your age. It will depend on whether or not you're fit to undergo chemotherapy and radiotherapy. So there's a lot of factors that we take into account when we make this plan. So once the plan is made, of course, we put it across to the patient, and the final decision, of course, is the patient's. And then we will tell you what we feel that would be good for you. So I'm a surgeon, breast surgeon, so I'll mainly focus on the types of surgeries. So if we talk about surgery for the breast, you can divide it into two components. One thing is surgery for the breast, and the next part is the surgery for the armpit or axilla. Surgery for the breast. So most ladies are really worried to come to us when they have a breast lump, because they think that if it is diagnosed as cancer, that they are definitely going to lose their breast. This is a wrong concept that people have. In this day and age, as surgeons, we always try to, where possible, to try and preserve the breast, because we understand that it is a very important thing for a lady, emotionally, psychologically, cosmetically, and functionally. It is an important thing. So if you come early enough, it is easier for us to help you, because we will be able to do what we call breast conservation surgery, where we try to remove only the cancer with some good tissues around it, and we try to recreate the breast to have a cosmetically acceptable outcome. That is breast conservation surgery. If for some reason, say there is multiple foci of the cancer in that breast, or the type of cancer is very aggressive where we cannot leave the breast, in that case, unfortunately, we would have to go for a mastectomy or removal of the total breast. However, there are multiple ways of reconstructing the breast in this day and age. It might be in the same setting that you do the mastectomy, or it might be done at a later date. There are different ways. We can use one's own tissues. We call that autologous tissues to create it. So we can sometimes take muscle flaps, including the fat and skin from the back, or maybe from the tummy. There are multiple ways that we can do that to recreate the breast. Or we can use some external product like a prosthesis, where we can use a prosthesis and try to create that breast back into and cosmetically acceptable thing. If by any chance we cannot match the size, we always can go ahead and do some change, maybe reduce it on the opposite side to basically get a cosmetically acceptable, balanced appearance. So please don't worry about having to remove your breast if you have a breast lump. Please come and see a doctor, because we will always try to help you not to lose your breast. That's about the surgery for the breast. The surgery for the armpit. In the good old days, we used to always go and remove all the lymph nodes in the armpit, because that is one of the first places that we know that the breast cancer cells spread to. However, there was a lot of negative outcome with the arm getting swollen and painful and numbness, and there were a lot of problems. So nowadays we only remove it if it's really, really necessary. If at the time of diagnosis we detect that there are cells, then we plan for the removal of all these lymph nodes in one go. If not, at the time of surgery, we do something called sentinel lymph node biopsy, where on the table itself we inject a dye to the breast and we find the first draining lymph node. We generally use a blue dye, and we look for a blue lymph node in the armpit, and at that time itself we send it for testing. Why? So you don't need to have two surgeries for this. If by any chance they do have cancer cells, then of course we need to remove the rest of the lymph nodes. But if there aren't, we leave the axilla alone. So that will decrease the morbidity for these patients.
Doctor, but what age would patients present with these conditions, with the youngest age? Because it's good to know, instead of, people either associate some of these ailments with like middle age or even older.
Actually, that's one of the important factors I wanted to come to. So what I was talking to you, I told you at the very beginning, you can divide the population into two categories. That is patients who have symptoms. So what I've been talking about all this time is what you do if you have a symptom. But I told you at the very beginning, the important thing about breast cancer is if it is detected early, it is curable. So there are two ways that you can do this. And when I mean early, we are talking about it to be detected even before you have any symptom. So the first thing, most important thing is breast cancer screening. This is something that most other countries actually run breast cancer screening programs regularly, where they invite all ladies to come in and get themselves screened. In Sri Lanka, we don't have hard and fast fixed guidelines because we don't have enough data to do that. So we most of the time go according to foreign countries' data. In UK, for example, they start at the age of 50 and they do it every 3 yearly, whereas Australia and US, they start at the age of 40. So we have noted in our clinical practice, we have seen that there are actually quite a number of patients within this 40 to 49 category. So because of that, we generally recommend breast cancer screening to be started at 40 years of age. And what do you mean by breast cancer screening? That is basically a screening mammogram. As I told you earlier, it is basically you need to go and get yourself a mammogram done. If by any chance, and also I need to stress on the point, you don't have to have any symptoms to get this done. As a regular thing, you need to be aware of it and because this is going to save your breast and your life both. So you need to get a breast mammogram done. We generally recommend it to be done every 2 yearly. And if there is, of course, any high risk factor, say for example, if you have a family history of breast cancer, that puts you at a higher risk. In those cases, or in those ladies, we recommend it to be done annually. So the decision as to how frequently it needs to be done needs to be assessed by a doctor, but we have to go for breast cancer screening.
Yeah, that answers my question because good to know. I would have thought even younger than 40.
Yes,
in some cases.
That is a good point. So basically for asymptomatic patients, we recommend the cutoff to be starting point to be 40. But having said that, as I told you earlier, you would be in a high risk if you have family history. Now, when I talk about family history, not every patient who gets breast cancer actually has a family history. But if you do have a family history, it puts you at a higher risk. And we are mainly concerned about your first degree relatives. First degree relatives means if it's your mother, your grandmother, a sister, a brother, then of course that means that you are at a higher risk to develop breast cancer and also ovarian cancer also. So if you have one first degree relative, it puts you at a twofold higher risk. If you have 2 or more, it puts you at a 3-fold higher risk. So for them, you may need to start at an age earlier than 40. The recommendation is you have to start yourself getting screened 10 years prior to the age of the first relative, the age of the relative who was diagnosed with cancer. 10 years earlier than that is when you need to start. For example, if your mother was diagnosed at 45 years of age, you need to start screening at 35 years of age.
So that's a good yardstick to go by.
Yes.
Thank you, Doctor. So time is catching up with us, and I would ask you to give us your take-home message.
Breast cancer is a very important thing for all females. Everyone has to be aware of it, and you need to spread the message. If you have daughters, teach your daughters about this. And the most important thing is, if it is detected early, it is curable. That's the most important thing. So get yourselves regularly screened. You have to do self breast examinations, and make sure that if you have the slightest doubt, if you have any early symptom, don't wait till late. Immediately go and see the doctor, because as I told you, if you come early, we can help you get cured and also to save your breast.
Thank you, Doctor. Very interesting indeed. And on that note, we end our discussion on breast cancer. And thank you very much, Dr. Thathya De Silva, Consultant General Surgeon with a special interest in breast surgery attached to the Army Hospital in Colombo, for being with us in the midst of your busy schedule to speak to our listeners on this very vital topic, especially the women out there listening to us. Thank you so much.
All right, thank you.
My thanks also go to Thathya De Silva for technical assistance. I'm Fatima Razi Kadi saying good night, and once again taking this opportunity to wish each and every one of you a year full of health in 2021 and beyond.